Who has not seen a nephrostomy tube? Or nephroureteral stent? Or a ureteral stent? Okay? So try to think about what questions you might have, and then we'll definitely have a section for Q&A at the end. So the topic today is to talk about IR percutaneous nephrostomy tube placements, nephroureteral stents. We're not going to include ureteral stents, which we also place, or weird complex stuff that we sometimes do. I'm also not going to talk about nephroureteral tube exchange. Well, we'll cover that a little bit, but the point is that once you talk about the placement, then everything else should make a lot of sense. So first we're going to actually talk about the anatomy and the indications, because I think that sets the stage of what we're thinking, why we're doing things the way we do, and what tools we use. Okay, so do you mind sharing the first website page? Thanks, Trace. So this is stuff that you guys probably already know. The first one, thank you. Okay, so obviously the kidneys are two organs that are in the back. It's technically outside the abdomen. It is in what we call the retroperitoneal space. Why does that matter? It's because any damage we do to it is isolated from the rest of the gut, liver, spleen, pancreas, all this other stuff that's nearby. The kidneys, as you guys know, obviously filter blood. If you kind of look at this, and we're going to look at this on ultrasound and what it looks like, the majority of the blood flow actually goes all the way to the outer part of the kidney called the cortex, and that's where a lot of the action happens. That's where all the filtering happens. And then the urine then gets concentrated along what we call the calyces, which are on the outer part, down into the renal pelvis, and then finally, in most people, it forms one ureter and goes all the way down into the bladder on each side. In about a certain percent of people, they actually, because of the way that you're just made, you have more than one collecting system on both sides. You can have an upper pole moiety and a lower pole moiety. You can have two ureters. When somebody has complete duplication of two ureters, they oftentimes don't both insert onto the bladder. And so what that means is that somebody might be draining urine from somewhere close to the bladder, and that's what they've always known. And then urology can't always figure out why is my stent not going in the part that's obstructed. Well, it's because you actually never were in the other ureter. So the kidneys, the interesting part about it is that obviously when we make urine, it's completely sterile. When it goes down to the bladder, it should be sterile. It's the outer part that's not sterile. And so the other thing is that the kidneys get about 20% of the blood of your cardiac output. The kidneys are one of the most vascularized organs in the body, which from our standpoint matters because it can bleed like a stink. And also, if it gets infected, which is one of the most common causes we do perc nephs for, people can go downhill extremely fast. Okay, can you show the next picture, please? The next website? Thanks, Trace. So this is what an obstructed kidney looks like. So the kidneys filter urine, and of course, there's a lot of crystals in urine. And people make stones. Some people just make a lot of stones. And when we make stones, small stones that are about 5 millimeters smaller, that's the teaching, they can pass. They hurt like hell, but they can pass. Larger stones tend to get stuck, and there's two main places that kidney stones get stuck. Where the renal pelvis hits the ureter, that's called the UPJ, and at the very bottom of the ureter when it inserts into the bladder, it's called the UVJ. Stones are going to be one of those two places. And so this is a picture of an obstructed kidney. It's all big, it's all swollen, and then there's that stone there, okay? So, and then do you mind showing the first PAX picture, please?
Can you go to the first PAX picture?
Thank you. All right, so the indication, so this is gonna be a group exercise. So name one of the most common causes for perc nephs. Hydro, right? Obstruction, right? So somebody has obstruction. Oftentimes it's from a stone. What are other causes of urinary obstruction other than a stone?
Perf of the ureter, if it's perfed.
Okay, so we're going to talk about perfs a little bit separately because that could, or it may or may not cause an obstruction. But any mass lower down, okay, so a big mass that's pressing on either the ureter or ureters or bladder, bladder masses can do it, and then there's ureteral cancers that actually just grow inside and then they start to bleed and then the whole system clots off and now the kidneys are just obstructed. Okay, good. So stones, masses. Another thing is that when there's a mass and obstructing the person goes into renal failure. Okay, and so if you don't decompress the kidneys in time, the person's going to lose both kidneys. Sometimes it happens slowly. Sometimes people are outpatients and they come in. Sometimes it happens very quickly, and then you're putting in, depending on the location of the obstruction, you might be putting in one perc neph or both perc nephs. Okay? If the obstruction is lower down below the bladder, say if the person has a urethral mass or some sort of pelvic mass, you might be putting in a suprapubic tube rather than two perc nephs, just because it's nicer for the patient, right? Other causes of perc nephs. Well, so one is obstruction, as we said, for different causes. The next one is actually urinary diversion. Okay, so common case, somebody has surgery, let's say, uterine surgery, a young mom has some sort of C-section or something, the surgeon accidentally cuts the ureter. Not uncommon, ureteral injuries. Other masses, things with the colon, everything else in this part of the body that can injure the ureters, sometimes the person's just leaking urine into their body. In such a case, the kidney may be not obstructed, but they're just peeing freely into their body, and so we put in perc nephs to divert the urine away so that then the ureter has a chance to heal. Or sometimes we put something further down so that we act as a scaffold for the ureter to heal around our stent or our tube. Okay. The last reason why we oftentimes do perc nephs is for something called pre-PCNL access, which some of you guys have seen. And so when there's a large stone, so stones start, they get bigger and bigger and bigger. At some point they become a huge rock. And it could be so big, it could fill the whole kidney, and there's no real easy way to get it out. So what the urologists do is they actually put a scope, a rigid scope, that's like 26 to 30 French, in from the back, into the kidney, and they macerate the stone and they yank it out in pieces. In order for them to do that, we have to then access the kidney for them and put in enough of a wire such that they can follow our path to go in. And if we don't access the right trajectory, they won't be able to do their part and then they can't bring up the stone. Okay, so those are the most common causes for why we do perc nephs. All right. So obviously the kidneys are in the back, and so this is a patient that we did a perc neph for back in March of this year. This person has already a ureteral stent, which is going all the way down into their bladder, but the stent oftentimes gets obstructed. Ureteral stents that that urology place are oftentimes only 6 French or so, 6 to 8 French, and they just tend to get occluded very quickly. And so not uncommon for us to have to put perc nephs in those situations. This part of the body, so this is obviously a CT scan, and a CT scan, a person's lying on their back. When you put the person ideally in a prone position, which is the best way to see this when we do our procedure, everything moves around. Colon, which is here and here, tends to sometimes move to the back. Other things move, and also the kidneys are right behind our lowest ribs. And when we put somebody prone, they tend to just not take very deep breaths. So then the kidneys ascend behind the ribs, and then we give them sedation, and then the breath gets even shallower, and then it ascends even higher, and sometimes we cannot see the kidneys on ultrasound. And so because of that, we tend to be very careful as to, do we go between the ribs, do we go underneath the ribs and partially see it? We have to really think about how do we position the patient and how do we use the ultrasound to identify our landmarks before we go in. To get an example of what a kidney looks like, if somebody wants to be ultrasounded, you don't have to feel pressured, but do you guys want to be ultrasounded? Okay, so how about this? How about, if you don't mind sitting here, facing that way, and I'll ultrasound you from the back, and then you guys can see this. Right? All right.
Almost 60.
Do you guys have towels? Towels? Yeah, thank you. Do you mind lifting the towel? Thank you so much. Thank you for volunteering. Alright. Is that a stone?
That's the one thing I was like, we need to talk later.
I said I
Like,
could walk
damn
off the hill, I'm
it.
almost 60. I wonder if I
Alright,
could.
so standard ultrasound techniques. Did Dr. Shu talk about the difference between these two probes? Like, what is the real difference between these two probes? Okay, so Diane, what's the difference between them other than the shape?
Other than the shape, the depth of penetration,
Okay, and do you guys know what's affecting the depth on these?
the hertz.
Right, so the megahertz on these is the 6 to 13 megahertz and 2 to 5 megahertz, okay? So lower frequencies penetrate deeper, higher frequencies don't penetrate as far. If you guys are like sonar technologists and something like that, that's all like go through. Anyway, whatever. So the reason for that is that higher frequency dissipates very fast. The loss of energy occurs much quicker than low frequency. However, upper frequencies have much higher spatial resolution than low frequency. Okay, so when we target small things, blood vessels, when you place a pick, when you're looking at shallow things in the neck, we use this. Okay, deep objects, liver, 10 centimeters in, 15 centimeters. Kidneys in people that are, some of our patients are large, we always use this. We almost never use this for kidneys, okay? There's many settings on this machine that determine how the picture looks. It has to do with the way that the image is processed and the frequency they use. We almost always, out of all of these, only use the abdomen mode. If you guys want, feel free to try the other modes and then you can see how different the kidneys would look, okay? So, we should help. All right, so we obviously put this on curvilinear mode. One of the things is that you guys sometimes see me messing with this panel here, and you guys can see this. This thing, which is actually a lot more, so this is kind of like the automatic point and shoot camera, okay? If you have the SLR version of an ultrasound machine, there's way more knobs that this thing's not allowing you to move. But when you look at deep objects, what this is called is something called time gain compensation, TGC, on other machines. Some ultrasound machines have like 8 different levers in a bunch of rows. What it is as the sound waves go deeper and deeper away from the body, the loss of energy makes the image darker and darker, and soon you can't see. And what it's doing is it's actually bumping up, it's amplifying the signal from the farther points of the body to even out the loss of signal. So in somebody who's larger, I mean, obviously doesn't apply to him, but sometimes we move the lower ones a little bit brighter just to get a better picture. Okay, so now we're gonna ultrasound him. The right kidney is always lower than the left kidney because of the liver, okay? So when I put this on the back, I'm putting it at an angle to his ribs because the ribs kind of come down like a Christmas tree, right? And so when I'm scanning, I'm gonna make this all brighter. That is actually liver, and this is all bowel. Okay, so I'm gonna scan a little bit lower, and you kind of have to look around, and that is his right kidney. Okay, sometimes very, very, very difficult to see. Do you guys see that right in the middle of the screen? Okay, why am I only seeing such a horrible picture that doesn't look like textbook? Because I'm getting rib shadowing. Okay, so if you actually look at what this line is, this whole line is blank. There's actually another blank line here. Those are the ribs that are actually up there that you're not seeing. Okay, so all of this is digital signal processing, and you have to kind of like read the matrix to understand exactly what's going on with ultrasound pictures. If I actually turn this, so now I'm actually in line with the ribs, now you can see a rib completely in the way. And so if we were to access the kidney, this would be the relative location we're looking for. Okay, now whenever we access things on a ultrasound, obviously I can't put the needle through the center of the probe. I have to put it around the probe, right? So the around the probe means I'm either coming from this angle or I'm coming from this angle. This angle is a problem because you see this bright line. Do you guys know what that is? This bright line that's shadowing, that is bowel. Okay? And you do not want to put a perc neph through bowel. I've done it. It sucks because then they need surgery to fix that. So, and so you kind of have to move around and figure out what's the best way to do it. And so if we had to put a perc neph in him, he would actually be a very difficult perc neph in this, obviously in this position, okay? All right, so, so the thing is, thank you very much, appreciate it. Okay, so, so positioning. The ideal position for perc nephs is prone. The reason for that has many reasons. First of all, easier to see on ultrasound because almost all perc nephs come from lateral to medial. Okay? If you have somebody who's like lying on their side, sometimes that's doable, sometimes it's not. The other problem is that when you start imaging, oftentimes the kidney does not look normal. And when you're imaging and you poke something and you're not sure if you're in and you start injecting contrast, if you don't get something that looks like a kidney, you might not be in the kidney. And you won't know unless you can get a true AP picture. And if somebody's lying on their side, now you're rotating this whole thing 90 degrees just to see the kidney. And that's why it's so difficult. And people have placed perc nephs into the wrong organ before. Okay, which is why I'm pretty adamant about prone imaging. What do we think about when we're worried about prone imaging? Well, the classic scary situation is, you know, patient comes in through the ER, 89-year-old woman, she's got congestive heart failure, she's got pulmonary edema, and she came in septic shock. Okay, and she's got an obstructive stone. All this trapped urine has nowhere to go because the stone's not letting the infected urine out. And the bugs have nowhere to go other than her bloodstream, and she's now having essentially E. coli septic shock. The teaching is you never let the sun go down on an obstructed kidney. That's actually something that anybody, like any medical student would be like, oh yeah, that's just the same. The reason why it's true is because these people might have hours before they die. Okay? And so that's the reason why we come in the middle of the night to do these things. And that's actually the reason why sometimes they're on pressors, sometimes they're so unstable that if you put this imaginary patient prone and you sedate them, they might just code. And times like that, we sometimes ask anesthesia to intubate them in advance so that we have more reserve. And that's the reason why those cases we want to work quickly. And when we're doing these steps, we kind of want to minimize the time that the patient is on our table because the complication clock is going. Okay. All right. So before we talk about supplies, what are the steps of a perc neph? Jake, first step of a perc neph.
Lido, ultrasound, access, wire, introducer, 035 wire, perc neph.
Okay, fine. So those were all the steps. Good job. All right, so
Thanks.
Good job. All right, so am I allowed to open any of this stuff?
Yeah, it's fine. I'll use it to teach you later.
Okay. So when you have a difficult kidney, Mackenzie? Yeah. Do you mind pulling up the perc neph on this patient? It's to the right. If you scroll on the scroller, the horizontal scroller. Sorry. I already opened it. Yeah. Can you show those images? Thanks. Okay, so this is what this kidney looked like. Are you sure that's the kidney? Hard to know. Like if that were you, are you sure enough that this is your kidney and put a tube into? Okay, that's the question in my mind. And that's why oftentimes when we're not sure, I would say, you know what, let the doc know, hey, this doesn't really look like a normal kidney based on, you know, how comfortable you feel. Do you mind coming to a scan? Totally cool, right? Because what we don't want is to be faked out. Once you drape and everything, nobody wants to move the drape, and then now the window's only that big. And when you're scanning, it's like, I think that's a kidney, but I didn't scan around here and here, so I don't know if maybe this is bowel or some other organ. right? So that's why scanning is really important, and we cheat because we look at this in advance, so we kind of have certain landmarks, okay? So for example, this patient actually has a stent in there. This bright line is the stent, okay? So we cheat and look at like stone configurations and stuff like that just to know where we're at, okay? So when you access this, you can look at the ultrasound and see how deep it is. The markers aren't necessarily on this, and you can measure it. On this, obviously, you know how deep it is. And so that actually automatically limits what access needle you use. There's a reason why acoustics are this long. It's so that you can access deep structures. Another reason, here goes a few $100. Another reason why we use it is because, do you guys know the gauge of this needle? 21 gauge needle, right? Not uncommon to have to stick the kidney multiple times, right? The kidney, as we said, is a highly vascularized organ. The worst thing, nobody cares about a venous bleed, I mean people do, but the worst thing you want to do is to hit an artery, right? Then now you've got a septic shock person that you've got to then stick a tube in and flip them and then do an embo, right? Not something you want to do. That's the reason why we don't stick things with an 18 gauge, okay? You stick this, you can stick this multiple times. So you're sticking under ultrasound, and especially for really difficult cases like the PCNL I'm going to show next. Every time you stick under ultrasound, when you remove this, air goes in. Okay. So sometimes if you're not sure where you are, and then we actually hook up a syringe of contrast and we inject, that's why we're super careful about air, and oftentimes we do a wet-to-wet seal when we hook up our tubing. Okay, so we pull this out, make sure it's covered with saline or whatever, and then we hook up, because once you inject air, as we've shown, air, like in bowel, completely obscures everything, and when you have air in the collecting systems, your case is like over. That's like one of those things that like people it's just a complete no-no. Okay. Similarly, if you're not in the kidney and you start injecting contrast, the contrast is just going to sit on the screen, and that's what we call like a blob fest. After a while, there's so much contrast you can't even see the kidney anymore, and then it makes the whole case very, very difficult. Okay, so oftentimes when we inject, we use very little contrast, and we're very deliberate about when to use contrast versus just seeing urine come out. Okay, so you put this in. We said this is a 21 gauge needle. What size of wire goes through a 21 gauge needle?
021.
5.
No, 021.
Smaller.
I don't know, you guys tell me.
It's 021.
018. Okay.
018 goes through?
018s go through a 21 gauge needle. 025s do not. 035s do not. Okay? 21 gauge, whatever, but yes. Okay, so the first wire that they give you, if I haven't lost it, is your 018 wire. And so the 018 wire is also known, some people use something called a coke wire, but the only purpose of this is that there's a flop on it that allows you to curl into the kidney. Can you show the first floral picture, please? Thanks. Okay, so here's a stent, this needle followed by this wire, okay? The things that we are thinking about in our mind when you put this in, how sure am I that I'm in the kidney? Okay, you think you're in on ultrasound, you poke it, you open this up, urine doesn't come out. Is it because you're not in? Is it because the urine's too thick? Is it because there's blood? We don't know. What can you do? Well, you're gonna inject contrast, but then you're worried about putting in air. You're worried about blob festing, the whole thing. So then you put in a wire, and if the wire kind of curls in what you think it should look like, and then sometimes at that point, if I'm not sure, I'm using ultrasound again, which is why sometimes we like to keep the ultrasound machine around and don't put it away, right? In case we have to reaccess. You can see the wire coiling inside, and you're like, okay, good, I'm golden. Next thing we're thinking about is, what's the difference between the gray part and the black part of the wire?
Floppy and stiff.
The gray part and the black part?
Mm-hmm.
You can see
Floppy and stiff.
Floppy and stuff. This is the only part of the wire that's useful. The rest of this is just to be atraumatic. You cannot advance anything over the black part. In fact, this gray part might not even be enough if the person is large, and you have to now shove this thing through all the soft tissues. Okay? Why got a problem. If you don't have a straightforward trajectory, if the person is really thick, or this went right underneath the rib so that the trajectory is actually like this, and this is the reason why sometimes we open the cones all the way so we see the entire tract from skin entry all the way in on fluoro rather than coning all the way. It's because if you kink this, you have now lost access. And if you have to poke again and pull this out, that person might be leaking urine now through that hole, and you've got an infected urine going into the body. Okay. This, the only purpose of this, what French is this? 6. Good. Okay. Okay, so we said we want to poke it first, 8 less traumatic compared to an 18 gauge needle. 6 French is pretty traumatic. If I hit an artery, that's a 6 French hole. Okay, you guys know what 6 French holes do in the femoral artery, right? 6 French hole in the renal artery does exactly the same thing. Okay, so does anybody know the size of this? If this is 6, and this is a standard wall thickness catheter, what size is this? 4. Good, right? Same thing as like the sheath sizes, right? And so forth. If we're not sure we're in, we take this out and put this in. Why? Because once you put this in, and you take this out, you can inject through it. You can now see if there's urine return that you might not have gotten with this, simply because of the caliber difference. Okay? Super, super, super important when this is put on the wire for this to be screwed shut. Not uncommon. The front part comes loose. You're trying to push this in. Person staring at the screen, pushing. They're not looking down. This is coming off and not sharp. And then we kink the wire and then we lose access. Okay. This has to be screwed together. Don't screw things together too hard, because when this is in and now we can't undo it, that also is a problem, right? So we advance this over this. This is stiff. It's got a sharp, hard stiffener in it. It cannot make that final turn. And so what we do is that once we get this into the kidney, we actually start taking this off, and sometimes we then advance the last part over. Okay. This allows us to transition from a less traumatic system to a actual working wire. Okay. How do we pick what wire we use? Well, this is not going to go down the urine, probably. So the wires that we could have are, okay, now I've got this in there. What size wire do I want? 0.5, right? You guys agree? Okay. Why would I not put an 0.18 wire through this? Why would I not put this back through this?
Not enough support.
What does that mean?
It means it's not a rail, you won't have.
Yeah, that's right. I won't be able to push this guy over it. You can if you're lucky, but that's just a dumb thing to do, okay? So you want a working wire that's stiff, okay? So the different wires that we can use are this free wire. I don't even know what this is. This is like a pseudo-Benson, pseudo-Rosen thing. You can use a Rosen, you can use an Amplatz, you can use a Glide. And then there's other 035 wires that are a little bit more exotic that probably we shouldn't be using, okay? At least not for basic things like this. What lengths do I need? Do I need a really long wire or do I need a short wire? Why do I need a short wire?
Why do you need a short wire?
Yeah.
Because you're only going to the kidney.
And you don't want to have the possibility of it pulling out because it's so much
Okay, maybe,
length out there.
maybe. It's all driven by,
More support.
all driven by, well, how long is the per Neph?
35.
35, right? As long as I have 35 sticking out of the skin, we're good enough. If we were putting in this, a 75 Amplatz would not be long enough. Right? Now you need a 150, right? So it's all driven by this. What is the difference between a perc Neph and an APD drain?
Where the holes are.
Okay, what else? Good.
The length of it.
The length. Okay. So many people are going to be going home with a tube sticking out of the back. And the other thing is that the kidneys move up and down when you breathe. Okay? The outside world does not move up and down when you breathe, but inside does. So this tube is technically getting dragged in and out and in and out every time you breathe. Length is great. Plus, what do we attach at the end sometimes? And stopcock, right? Have you guys ever tried going to bed at night with a stopcock on your back? It sucks. And then if you do that for 3 months, it sucks even more when your skin breaks down. Okay, so this allows the stopcock to be further out on this side. Okay, and especially our unfortunate patients who live alone and have to try to change the bag or things like that, it's just such a pain. Okay, so longer tubing is for that purpose. Okay, so what sizes do these come in?
8, 10, 12, 14.
16.
These or these?
The Nephs go up to like 12, right?
Or not, you tell me.
8, 10, 14.
6.
I think there's no A's because they get caught.
I know for sure that all the companies make perk Nephs in 8 and 10. I would not know if they make it bigger than that.
Yeah.
Okay, I just don't know because it's extremely rare. So when you start out, because it's atraumatic, you could have still hit an artery and not know. We start by putting in the least traumatic thing, 8 French percutaneous nephrostomy tube. The holes are in a slightly different location. The holes, depending on the brand, are actually cut in a different shape than these to allow different drainage. Okay. Somebody gets an 8. So let's go back to this patient. Old patient, septic shock. We get this in, great. We get this in, great. We get this thing in. Sometimes we then inject contrast to make sure we didn't rupture the kidney. Sometimes you can actually be outside the kidney, but in the capsule and stuff around it, and it looks like the kidney, but you're not sure. That's why sometimes people take extra care. And then you put this in, you put this wire in. Okay, good. So 6 French system going to an 8 French perc Neph, you probably don't need a dilator, probably. If the pushing of this is a lot of resistance on feel, we might ask for an 8 dilator because we're just not sure, okay? So that's the reason why sometimes we use it. Rare for people to go straight to a 10 French from the get-go. You can, depending on the indication, but normally we put in an 8. So you put in the 8, pus starts coming out of our imaginary patient, okay? The reason why we oftentimes urge urgency when we're doing this is that when you put this in, you take this out over the wire, pus is now leaking into their body. And then you put this in, it clogs the hole. Now you've got a 6 French hole, take this out. Now we're like, oh crap, we didn't open a perc Neph. Oh, okay, let's go over to the shelves. Oh, it's in the other, oh, it's in the hallway. The whole time, the person's getting worse and worse and worse. Okay? So always have this thing ready because you just want to minimize the time between the exchanges. People have died during perc Nephs. People have coded afterwards and gotten a septic shock, and it's unfortunate. And we definitely try to prevent that from happening. Okay, so this goes in. The kidney's already unhappy. We stirred it up. Okay, and now pus is coming out. We collect the sample of pus. Oftentimes send it, give it to the nurse up there. We send it for sampling. Okay. Sometimes we don't inject, and the reason for that is that in an infected system, you want to decompress, you don't want to add pressure, and if somebody is overzealous, it goes BAM! You've just pushed all that bacteria into the bloodstream. Okay, and so that's why sometimes we don't do that. Okay, so now this is in, everybody's happy, you take your picture, it looks good. Can you go to the last picture on this? Thanks. It looks good. Looks pretty good. We tried it, this is the calyx, this is part of the renal pelvis, and then there's, here's the stump. So we try to put this all the way as far in as possible so that there's room to move back and forth when they breathe. Okay, some people stay fix this or grip lock on the outside of the skin. It's kind of crappy when a patient then moves and then yanks out their Neph tube, or they go home and then they're walking around with their bag and then it gets yanked out. So it's nice to sew it if your doc can. Ask your doc if they want to sew it or not. Long-term patients, like one of our patients who comes in all the time and gets tube changes under anesthesia, she doesn't like being sutured all the time, but she's had this tube for years, and that tract is mature, and there's less of a risk if it gets pulled out. And then at that point, the suture is more irritating than not suture. But fresh tubes, we should try to secure it extra carefully. Okay. Good. Do you put this to a JP bulb? Hold on. Good morning. Do you want to put this to a JP bulb or gravity bag?
Gravity bag.
Why?
Why? Because you're going to continuously produce urine, and it's going to be easier for the patient, for one thing. JP pulp, you don't need suction on this, you just need it to naturally.
Good, right. So even though if the kidney's infected like an abscess, you don't want to suck. There's several things in the body that you just don't want to put the JP. Kidney's one of them. Why do you need a 3-way stopcock or a 2-way stopcock?
So you can flush if it gets
Okay.
really.
So if you're putting it in for clean urine, you do not need to flush. Because when you flush, sometimes patients at home, they accidentally turn it off and now it's off and now it's obstructed. Or they flush themselves and they're not sterile and they give themselves an infection. Okay, so if it's straightforward, simple urine, sometimes you don't need a 3-way. Ask your doc. Don't assume, because there have been patients who come back to our clinic and they have an ulcer in their back because the 3-way has been rubbing them. Or they call us in the middle of the night, my tube's not making urine, come to the ER, 8 hours later, we go see them, they turn it off. Okay, not uncommon. Or it's leaking, there's something wrong with the tube, oh, that's because they were messing with it and they unscrewed it. Okay, so every time we put something on, it's a point of potential failure that can happen, right? So, or something wrong can happen. Good, gravity bag. Okay, good. Any questions so far?
So you're saying we should ask the doctor about the 3-way or the 1-way that comes with the tubing?
Yes.
Hey, do you want it? Yes, no?
Yes.
Okay.
I also have a comment about the one-way that comes with the tubing. There's a one-way that comes in our pack, and the lumen for the one-way that comes in our pack is smaller than the one that comes through the tubing, so make sure you don't mix them up because you want free flowing as much as possible.
Mackenzie, do you mind loading the other MRN, please? Thank you. The one I sent you. Thank you.
At least that's what I was taught a long time ago, is that correct?
Yeah, I mean, the thing is, every time we put on connectors, including 3-ways, oftentimes the lumen is
No,
really
it's just a one-way.
or 1-way, 3-ways, a lot of times the connector is really small. In fact, even if you look at drainage bags, the little lure, the lumen of it is actually really small. So if you have really thick stuff coming out, you got to think about those things, otherwise the flow might not come out. But to your point. I forgot to say, why different wires? So, go to the KUB, okay. The KUB and then the perc Neph, please. Or that one, yeah, or the IVP is fine and the perc Neph is fine. Sorry. Thank you. So why wires, by the way? Glides are not as stiff. Bensons are a little bit as stiff if you have a stiff glide. Rosens are more stiff. Amplats is the most stiff. But remember, a 75 Amplats has a long flop, at least the ones we order, and that 7-centimeter flop is useless. So you gotta curl a lot of it in, and so that's the reason why sometimes we might change to a different wire when we don't have much purchase. Are you guys all familiar with that term, purchase? Yeah, okay. All right, so we oftentimes want to make sure we have enough wire. Good. This is a case that we did of somebody who has an obstructive stone. Okay, so can you show the perc Neph pictures, please? So this is a pre-PCNO access, and the goal of this, similar to perc Neph, is so that the urologist can then follow our line and go in. And you can actually see on the, go to the first picture, yeah, perfect. And then can you also pull up the ultrasound? Thank you. Okay. Kidney, and then scroll on the ultrasound. Yeah, okay, good. This is the stone. Sometimes hard to tell, right? If you've got more ribs, you'd be like, it's not even a kidney. Ultrasound is just tricky. And so, again, we cheated. We looked at the CT, so we know where the stone is. And then luckily on fluoro, you can see a stone. Okay, now, so this case is different than the last case. The last case was all obstructed. Our imaginary patient was all obstructed. These are often have not obstructed, they just have a big stone. So now you're trying to stick into a non-dilated system, which is very interesting, right? And And so in this case, can you play the first fluoro? Yep. So you can actually see what we're pushing on the stone. Okay. So you hit it, you can feel it, the needle's hitting rock. And then you're just like, boing, 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 like, oh look, I'm there. Okay, you know for sure you're in. And then if you're not sure, you can actually always rotate the eye different angles. And if you're really hitting this, you should always be on, right? There shouldn't be an angle where you're not touching it. In cases like this, the goal is to get a wire in or down to the bladder. You have to get past this rug. This wire is great because it's stiff and gives you support to put in this. This wire is, and it's highly visible. This wire is not great because this wire, similar to the micropuncture wire and similar to something called the cope wire, this is like a pseudo-cope wire, is that if this comes out at a really sharp angle like that, if you try to pull it back, you could shear it off on this needle. And people have left fragments of wires in the kidney before. And if it's crumbling and you can't get it past the stone, other 018 or smaller wires we might ask for are nitrix, glide, rarely V18. Do you know why we don't want to use a V18? It's too stiff, right? And you can actually go through and through the kidney. That's the same reason why. So, because I don't think Dr. Shi talked about this on the last topic for lines and central venous devices, but the choice of wires in IR do not overlap with the choice of wires in cardiology or vascular surgery. The wires are all designed for a specific part of the body. And so some of the wires that are used, say for tibial drilling, or other things like recan wires, we do not use in IR unless we're down in the leg. Okay. And so those are some of the 018 wires we might use. Slightly rarer than the typical perc Nephs, and then we'll ask for those when the time comes. But you should always think about them depending on the case that we're doing, so that you have an idea if the doc gets asked for it, where to get them. Okay. Do you guys know where to get those wires? Does anybody not know where all those wires that we just named are listed? Okay, good. It's good to identify this, because when we ask for it and then people are like, I don't know where it is, then we're going to say, well, we had this training, so I thought everybody did. So, okay, good. So we should review that. So Trace and Mackenzie will, of course, review all the supplies and everything afterwards as to where things are. Okay, good. Good, good, good. When somebody has a perc Neph in, when they come back for routine exchanges, the part that's bad about 8 French is that they're just small. They tend to get kinked. They tend to get clogged. We oftentimes upsize to a 10. Because of trauma, and because when you get out at some point in the future, you don't want to have a leaking hole, we oftentimes don't go above 10. It's rare to go above 10. The patients that you guys have seen that have like the 14 pigtail in their back, the reason why they have a 14 pigtail is because I don't think we've got 14 Nephs. Do we actually have 14 Nephs? I don't think we do. I think for her, we actually put in a pigtail. Yeah, so some people just make so much stones and crystals, they clog up a 10 all the time, and because she flies down from another state, we put in larger tubes for her. But that's not typical, and you should not treat that as a typical person case. Okay. Good. Another thing about the septic patient, just before I forget, is that that's the reason why we oftentimes want antibiotics loaded in their system before we poke, so that we minimize the chance of them getting septic. And of course, we worry about their airway, and we just want to do that pretty quick. All right, good. As for suture on the outside, if you put in an 8 French tube, it's hard to sew and secure an 8 French tube. If you use a non-braided permanent suture, oftentimes you have to kind of tighten it enough to just barely cinch down or kind of almost kink the tube a little bit. An 8 French tube loves to be occluded. So sometimes you see us actually putting the stiffener back in it when we sew down on it for that purpose, or we use silk, because silk, for the same amount of tension, grips a lot more than monosew. Okay. All right. So this patient, imagine this patient has her perc Neph, and then they can't get out the stone. At some point, people don't like carrying around bags, their whole life. And so that's when we go to a nephroureteral stent, okay? So what a nephroureteral stent is it's a perc Neph, at least the first part of it, to here. And then it goes all the way down, all the way to the bladder. And I tell people this is kind of like a soaker hose that I buy at Home Depot. It's got holes throughout the whole thing. And this is similar to the next topic of biliary stents. This allows you to have external drainage. It also allows you to put a cap on it, and now it's an internalized stent. And so for a lot of our patients, they've had Pertinax, and now they're sick of carrying on a bag. We convert it to one of these. It opens up the ureter all the way down. And depending on what was going on with their ureter, if it's a stone down there or a mass or whatever, it could be really hard to get this thing down. But if you can cross the obstruction and go all the way down, once this tube is in, it allows you to have the option of detaching the bag, putting a cap on the inside. Now urine goes through the stent down to the bladder, just like a normal kidney on the other side, and now they pee normally. And all they'll have is a little nubbin sticking out of the back. Okay. When we put it in, sometimes we're not sure it's going to stay open, so we still put it into a bag to decompress them, and then we tell them a week later, come back and put a cap on it. Okay. These are also nice because if the person yanks it out, they've got like an extra 6 inches to yank before the whole thing actually comes out, so that's why these are nice. Okay. Do you know what size these come in? So diameters and lengths.
So 13 and a half, and 26, 24, 22.
Yeah, so the 13 and a half is like a specialty product. Okay, so these come in 8.5 and 10.2 French. Okay, those are just the only two sizes. Simply because those are the sizes people make, decent, right? 8 and 10. And so they come in different lengths. And the lengths we actually measure from the distance of the renal pelvis down to the bladder. If we put in the wrong length, you have a piece of plastic that's pushing against their bladder all the time, and patients absolutely hate it. I mean, they will tell you, oh, I feel like I've got to pee all the time, and it sucks. I mean, can you imagine, like, all night you feel like I'm peeing?
Irritated.
Right. And so we oftentimes have to measure the length, and then we have to form it correctly. And so that's it. Okay. That's almost all the topics that I have, and it's almost an hour. What questions do you guys have?
Can you talk about the plastic stiffener for the prostatic?
Oh, yes, thank you. I'm gonna open this then. Right, so like all of our drains, it comes with two things. In my embarrassing moment without licking my fingers in the lab.
See? We just make it look easy.
You guys are so bored like that.
You animal.
I know. Okay, good. So why are there like two things all the time, right? Well, when you're making that initial hole in the body, it's really hard to do that even over an amplat sometimes because we all have just a lot of stuff in that part of the body. You've got muscles, you've got sometimes a rib in the way, you've got all this stuff. And so this allows great pushability for the metal stiffener when you're making an initial tract. Once the tract maturizes or so on exchanges, we don't use this because this is too traumatic and we switch to this. If we switched it around so that we place it with the plastic, if you're lucky you can get it in, but what you don't want is you don't want to kink this wire because this is way stronger than this, and if you're in the wrong trajectory, you will kink this. And then now nothing goes over it, and now you have to somehow exchange and kink the wire. And then if you're trying to if you're trying to push it in on this, then that's when things might not follow. In terms of wires, the stiffer your wire is to give you better support, the easier it is to kink. Right? It's more rigid.
That's right. That easy to kink, are they?
Oh yeah.
I didn't see a kink on that.
Yeah, you can kink anything.
Oh, that's true.
Glides are different to kink.
That's
But yeah. The reason why we don't oftentimes use a glide for these is that it's very, very, very hard to imagine you only have this much access in the kidney, right? I mean, your kidneys aren't that big. The kidneys are like, that big, right? So imagine you've got like this much wire in there. You're pin pulling a hydrophilic glide, and you don't want to lose that. Okay, so one word of advice on pin pulling, which I don't, everybody's pin pulling, but when this is in the body and somebody is taking out something, please ask, once you pin pull, ask, do you have the wire before you continue pulling the rest of it? Right, so this is out, like you pulled like this thing out, let's just say, before you continue pulling it the rest of the way. Dr. Chan, do you have the wire? Okay, so now I grab it at the skin. Yes, I've got the wire, and then people wipe or do whatever. The other thing is that when you're loading something on, when you're loading this on, one thing that I see people do is they put it on, and then when they're advancing it, they pull. Very common, okay? Don't pull. When you're advancing this, always have slack so that you're advancing it over the slack. And look at the patient and see if that doctor is now like doing something else, like staring at the ceiling or whatever. They're not holding the wire because people have lost access putting on tubes. Okay. We don't oftentimes mention it, but when we're holding it, you can actually feel the other person going tug, tug, tug when they're loading things, and we feel it. Okay, so just word of it, like trick of the trade, like be mindful of that. That's it for perc nephs and nephroureteral stents. What other questions do you guys have?
Is it a big turnaround for initial placements, like for patients, like you said septic shock, she's crap, ER, you put a Neph tube in,
Yeah.
is it a fast turnaround? Or is
So
it like weeks?
it depends on how sick they are, but the majority of cases get better within 2 days or so. Urology rarely comes up from below and unobstructs an infected system in the middle of the night, especially. So that's why we place these primarily. There is really no other option for these patients. If you don't do it, they're closed. So that's why we try to do them in the middle of the night. And if they're normal run-of-the-mill patient, they normally get better. Like you see the white count and everything get a lot better. Their pain gets a lot better within about a day or two. But some patients are so sick that they're like intubated in ICU, it can take a while. Yeah.
If you have a purulent kidney, do you want to drain as much of that out? Do you pull as much of that purulence out, or you just kind of leave it?
I think it depends on the doc. Some people want to just get it out as much as possible. Some other people believe that if you stir it up too much by like yanking it out, that you're actually introducing bacteria to the body. So it depends on the person. Some kidneys actually, when there's a chronic infection and it gets into something we call it XGP. It's when essentially your whole kidneys turn into a mold of jelly. We actually don't put in perc nephs on those, and they just get surgically removed.
Real quick on the exchanges.
Yeah. I'll look at the patient and decide how long are they going to have the tube. Are they expecting to have the tube removed in a few months and so forth? And we try to plan ahead to figure out what's the best thing for them. Yeah, good question. Another thing, before I forget, because I've been burned by this once. The difference between, so I know that our EPIC orders kind of are confusing. There is an IR nephrostomy and an IR nephroureteral order. Just be aware that whatever people order is often incorrect. So don't assume that what they ordered is actually what we're doing. We obviously look at the whole patient to figure out what we're doing beforehand. So there have been times when people are like, oh, we're doing a whatever biliary, or we're doing a nephroureteral stent, but instead we're only doing perc neph. And I've actually had a case where I actually had the wire in, and I wasn't looking at what was loaded on the tube, and then I actually put in the tube, and the tube had like I was wondering when I was advancing, like, wow, this tube feels longer than normal. But I didn't look down, and then I was just staring at the monitor, right, and all you see is the front pigtail form, and then I looked down, and urine was leaking out the entire way, and then I saw like 8 side holes sticking out from the skin. And what it was one of these got loaded on instead of this. And so essentially that soaker hose was just leaking pus all throughout their belly and whatever. you know, kind of silly that happened, right? I mean, you know, I should have looked, but if you're not sure, check with the doc. Like, hey, what kind of tube do you want? Just very easy, right? And then if they're like straightforward for Neph, then that'll be that. Okay. Okay, so I want to thank you guys for coming so early. It's amazing to see everybody, you know, so bright-eyed and whatever. I hope that this was somewhat useful. I know that everybody's done perfect, but the simple cases are when things can go wrong because we all take it for granted and we've done like hundreds of them. So just, you know, but really for that patient, it could be a really big deal if something happens. So, all right. Okay, thanks guys.
Thank you.
Thanks for coming.
Very quick for everybody.